Welcome to our lecture on traumatic brain injury. TBI is one of the most complex conditions you'll encounter as a physical therapist, ranging from mild concussions to severe injuries requiring months of rehabilitation. Let's get started. A traumatic brain injury is a sudden trauma, typically external, that damages the brain and disrupts normal brain function, sometimes causing substantial disability and mortality. TBI occurs through two major mechanical forces. The first is contact forces, where an object strikes the head or the brain strikes the inside of the skull. Falls, vehicle collisions, sports contacts, and assaults all fall into this category. Contact forces tend to cause localized damage, such as skull fractures, contusions, and focal brain injury at the point of impact. The second mechanism is acceleration-deceleration force, where sudden movement causes the brain to oscillate inside the skull. This can shear axons and blood vessels throughout the brain, producing diffuse axonal injury. Coup-contrecoup injury is the classic example. The coup injury occurs at the point of impact, and the contrecoup injury occurs on the opposite side as the brain rebounds. A single blow can produce damage at two distinct sites. In practice, patients often experience both contact and acceleration-deceleration forces simultaneously. Brain damage in TBI is divided into two phases. Primary damage occurs at the moment of impact and cannot be reversed. It includes both focal injuries like contusions, lacerations, and hematomas, and diffuse injuries like axonal shearing. Because diffuse axonal injury is distributed throughout the brain, it often does not appear on standard imaging, yet the deficits can be severe. Secondary damage develops minutes to days after the initial injury and is potentially preventable or treatable. Hypoxic ischemic injury results from poor oxygenation or circulation caused by post-trauma respiratory or cardiovascular instability. Swelling and edema raise intracranial pressure, which can progress to brain herniation if left unmanaged. Concussion sits at the mild end of the TBI spectrum. It represents a functional disruption at the cellular level rather than structural damage, which is why standard imaging typically appears normal. Loss of consciousness is not required and occurs in fewer than 10% of cases. Symptoms have rapid onset and are usually short-lived, though not always. As shown on the screen, TBI severity is classified into three levels based on loss of consciousness duration and Glasgow Coma Scale score. Mild TBI involves loss of consciousness of 30 minutes or less, with a Glasgow Coma Scale score of 13 to 15. Moderate TBI involves loss of consciousness between 30 minutes and 24 hours, with a score of 9 to 12. Severe TBI involves loss of consciousness beyond 24 hours and a score of 8 or below. The Glasgow Coma Scale assesses level of consciousness through three domains: eye-opening, verbal response, and motor response. As shown on the screen, eye-opening is scored 1 to 4, verbal response 1 to 5, and motor response 1 to 6. The total ranges from 3 to 15. A score of 13 to 15 is mild, 9 to 12 is moderate, and 8 or below is severe. Know this: the minimum possible. Glasgow Coma Scale score is 3, not 0. Each category contributes a minimum of 1 point. Note that on the motor subscale, a score of 3 reflects abnormal flexion, which is decorticate posturing. A score of 2 reflects abnormal extension, which is decerebrate posturing. Both posturing patterns indicate severe brain injury, but they are clinically distinct. Decorticate posturing results from damage above the brainstem. The upper extremities flex inward with elbows bent and fists clenched, while the lower extremities extend. Decerebrate posturing results from severe damage to the brainstem. Both upper and lower extremities are fully extended and internally rotated. It carries a worse prognosis. A patient progressing from decorticate to decerebrate is showing signs of worsening injury and requires immediate medical management. As shown on the screen, TBI produces symptoms across multiple systems. Sleep and emotional changes include sleeping too much or too little, anxiety and aggression. Cognitive symptoms include confusion and difficulty communicating. Sensory changes range from hearing and vision disturbances to hypersensitivity to light and sound. Vestibular symptoms like dizziness and balance problems are common and frequently outlast other symptoms. Physical symptoms include headache, nausea, and vomiting. Three standardized tools are used most commonly in TBI assessment. They are the Glasgow Coma Scale, the Rancho's Los Amigos Scale, and the Functional Independence Measure, or FIM for short. The Glasgow Coma Scale classifies injury severity through eye, verbal, and motor responses and is most useful in the acute phase. The Rancho Los Amigos Scale tracks cognitive function and behavioral recovery throughout the entire rehabilitation process. The Functional Independence Measure captures the patient's functional abilities and activities of daily living and documents gains over time. The Rancho Los Amigos Scale describes 8 levels of cognitive and behavioral recovery, running from no response at level 1 to purposeful and appropriate behavior at level 8. At levels 1 through 3, patients are unresponsive or showing only minimal, inconsistent reactions. The goal is maintaining range of motion and preventing complications. At level 4, confusion and agitation dominate. The environment needs to be structured with simple, familiar tasks. Levels 5 and 6 see the patient become more responsive but still confused, relying on external structure like memory logs and daily schedules. Levels 7 and 8 reflect meaningful independence, with level 8 marking the threshold for community reentry, vocational training, and balance training. You calibrate your interventions to where the patient currently sits and progress as they demonstrate readiness. In 10 to 15% of concussion cases, symptoms persist beyond 4 weeks. Core symptoms include persistent headache, dizziness, cognitive difficulties, fatigue, irritability, and sleep disruption. Risk factors include female sex, a history of migraines, pre-existing mood disorders, and multiple prior concussions. Graduated aerobic exercise starts below the patient's symptom threshold and increases gradually, rebuilding exercise tolerance. Cognitive pacing strategies teach patients to manage mental energy in smaller increments. Stepwise return to activity is essential because returning too soon is one of the most common reasons recovery stalls. In early-stage recovery, Rancho levels 1 through 3, the patient cannot move independently. Physical therapy focuses on preventing secondary complications. Passive range of motion, positioning, splints, and serial casting prevent contractures. Frequent turning and pressure relief techniques protect skin integrity. Respiratory care, including postural drainage, percussion, and suctioning, maintains a clear airway and reduces the risk of pneumonia. Sensory stimulation provides controlled visual, auditory, and tactile input to increase arousal. Upright positioning, even passively, improves alertness and engages postural systems early. At mid-level recovery, Rancho levels 4 through 6, the patient is more awake but confused and often agitated. The therapeutic focus shifts to providing structure and consistency. A quiet environment with reduced distractions, daily schedules, and memory logs gives the patient external organization their brain cannot yet provide. Consistent routines, clear feedback, and calm clinician behavior are all part of the intervention. Task-specific training uses familiar activities broken into manageable steps. Safety monitoring and behavior management remain constant priorities. At high-level recovery, Rancho levels 7 and 8, the goal is independence and community reintegration. Supervision is gradually reduced, and patients take on progressively more decision-making. Functional training moves into real-world environments, including home, workplace, and community settings. Balance training and cardiovascular conditioning address deconditioning from prolonged hospitalization. Patient and family education on the realities of community reentry is part of the physical therapist's role at this stage. For more videos like this, visit typicalpt.com. The full course covers every topic on the NPTE to help you pass the first time. Thanks for watching, and we'll see you in the next one.